I'd like to thank Dr. Walker for giving me the opportunity to be part of the NCVH Digital Education Series. My topic for today was endovascular approach to chronic total occlusions, crossing methods and devices. I'm Dr. Anish James Thomas. I'm an interventional cardiologist, vascular and endovascular physician with the Mercy Clinic, Heart and Vascular at Mercy Hospital South. For today, I've decided to focus on aorta-iliac intervention, as you can really spend the whole day talking about crossing chronic total occlusions anywhere in the lower extremities. When you talk about indications for aorta-iliac intervention, for an asymptomatic patient, it is appropriate to intervene on the iliacs for patients who require vascular access for another device, for example, mechanical circulatory support, or for procedures like transcatheter aortic valve replacement. In patients who are symptomatic with claudication, it's indicated in patients who have significant claudication, as long as you have a significant stenosis or a significant translesional gradient. And it's definitely indicated in patients with critical limb ischemia. This was the task classification. And when you talk about aorta-iliac disease, traditionally, it was always said that class A and B lesions are ideally suited for endovascular intervention, however, not so for class D and C and D lesions. This, of course, has changed in recent times, and we'll go over this. When you talk about access, this is key to your success. Often multiple points of access will be needed. Femoral access, brachial or radial access. In the last couple of years, with the advent of radial to peripheral interventions and the availability of longer sheaths, my preference has switched from brachial to getting more radial access when I need multiple points of access. It's therefore important to learn how to gain ultrasound-guided access. Learn how to do it. You may not have the ability to always use a roadmap for getting access, and we'll go through a situation where this is the case. Angiography is key before proceeding with any intervention. Get multiple views. Look at the proximal cap. Evaluate the proximal cap. Is it peaked? Is it a flush occlusion? Look and see where your collaterals come off from, and it's important to look at that. Evaluate the morphology of this. Be careful if it's a thrombotic occlusion as your intervention changes. Look at where the reconstitution point is. Once you've got your angiography done, you can evaluate whether you're going to treat predominantly from an antegrade or retrograde axis. You often need adequate sheath and guide support for crossing. Sometimes it's a lot easier to cross an iliac occlusion from above, however, may not always be the case. Traditionally, for crossing iliac occlusions, I've often used in the past 035 wires to start with. However, recently I've tried to use 018 wires initially and then escalate to an 035 strategy. However, if I see a microchannel, an 014 or an 018 wire works better, given that you have better torque control. If you cannot cross, sometimes you may have to use a reentry device like an Outback or a Pioneer. Initially, when you're starting off your experience, it's sometimes better to start with easy cases like task A and B cases. I'm going to show you a task B case and then move on to show you more complex cases. This was a case with an external iliac artery occlusion. If you can see over here, the external iliac artery is occluded just after its origin. The collateral flow to fill the common femoral is via the hypogastric artery. So in this case, if you have to deliver your sheath, you can either come from a radial approach. However, if you're coming from a contralateral approach, you will often have to use the hypogastric artery and wire into this to get your sheath up and over. Be careful in a situation like this, however, because if you damage or destroy the hypogastric artery during the procedure, that's your collateral flow to reconstituting the common femoral. In this case, I prefer to use a stiff support catheter or a braided support catheter, and it was fairly easy to cross. Once you cross, confirm that you're in the vessel, and then stented. We got an excellent post result. There was some moderate common femoral disease, as you can see, that we opted not to treat. What equipment do you use for revascularization. This was the SCAA guideline on device selection in aorta-iliac intervention. And if you look at this, for patients like this with an external iliac artery stenosis, you can use a self-expanding stent for diffuse external iliac artery disease. However, if it's a chronic total occlusion, you could use either a self-expanding or a balloon expandable platform, or even a covered stent. This is a little more of a more complex case. This was a patient with diffuse subtotal occlusive disease of the right common iliac artery, a dense calcified chronic total occlusion of the left common iliac artery with reconstitution at the external iliac. In this case, we opted to get access in the left common femoral as well. This was done under ultrasound guidance. We initially tried to cross the occlusion retrograde, given the lack of support I had from the contralateral approach. However, as you can see here, I was clearly subintimal at the reconstitution point. We then decided to get radial artery access and try to cross from above. You can see over here, you have the sheath, and then you have your support catheter, an angled support catheter right at the proximal cap. However, with this dense calcified occlusion, I was clearly subintimal at the reconstitution point. In cases like this, you have the option of trying either a cart or reverse cart or a safari technique. However, given that how far I was from the how far subintimal I was, I decided not to try and do this from an antegrade, but to use my retrograde access. And in this case, reenter, when you want to reenter, in this case, we had a proximal stump of the common iliac artery. And as you want to try and enter into this proximal stump rather than into the aorta. We were quite easily able to do this using an outback catheter, as you can see over here. From here, it became fairly simple. We did kissing stents in both iliac arteries. In this case, we used a balloon expandable covered stent in the left common iliac artery and a bare metal stent in the right common iliac artery. Given that we were able to do this in a kissing fashion rather than a crossed fashion in the distal aortic bifurcation, we were able to preserve an up and over port for future use should be needed. And this was the final angiogram. Moving on to another case. This was another case in which historically this patient presented with subacute onset of symptoms. As you can see in this case, the left external iliac artery is occluded. However, if you look at the angiogram carefully, there is some amount of evidence that there's thrombus in the distal left common iliac artery. If your wire goes through very easily, always suspect that this is a thrombotic occlusion. And this is what we suspected. And when you come to treating this case, you have options. You can either leave a lytic catheter and let it drip either for a few hours or overnight. However, in this case, we decided to do this in the same setting. We used a filter or an embolic protection device in the proximal SFA. Initially, we tried catheter-directed thrombolysis and thrombectomy, as you can see, using an angiojet. However, you can see there's still significant amount of residual thrombus in the proximal external iliac, as well as the proximal common femoral in this case. We then had to change strategy in this case. Following mechanical thrombectomy with the penumbra system, you can still see this significant large amount of thrombus in that proximal external iliac artery. We decided to use a covered stent, taking care to try and preserve the hypogastric artery, and ended up with an extremely good result with no residual stenosis or thrombus. We excluded the thrombus using the covered stent, and this was the result following mechanical thrombectomy. It's therefore extremely important to recognize when you have a thrombotic occlusion. Moving on to a TAS D case. This was a case with a distal aortic occlusion. If you can see here, just on the diagnostic angiogram, you cannot see the common femorals reconstitute. However, you could see that on the CT angiogram that I've shown you on the right. Here the common femorals reconstitute, and the collateral for this is actually the collateral pathway of Winslow, in which the common femorals reconstitute from bilateral internal mammary arteries through the inferior epigastric arteries. At this point in time, some may say this is a surgical case. However, I can argue today we can do this extremely safely with an endovascular approach. Crossing these sometimes can be challenging. However, in this case, for the most part, you will need a 3-point access. In this case, we got radial access and bilateral common femoral artery access using ultrasound. When you do this, it's careful. You've got to be careful. One way you can get your sheath is to access the distal common femoral artery and actually wire the lateral circumflex branch with a micropuncture kit. Once you do that, you can then get something like a pinnacle precision sheath into the common femoral artery. And from there on, you now have arterial access in bilateral common femoral arteries, as well as access from an antegrade from a radial or a brachial approach. Once you cross this occlusion, you can always upsize your sheath in the common femoral arteries. We did this. We were able to cross mostly from an antegrade approach from above, externalize the wire, and then get 7 French sheaths into bilateral common femoral arteries. From there, we were able to use balloon expandable covered stents in both common iliac arteries bilaterally and self-expanding stents in the external iliac arteries. What's the data for something like this? Well, if you look at TASTI lesions, the alternate surgical approach would have been something like an aortobifemoral approach. These patients, yes, they do have a good 5-year primary patency rate of about 86%. However, there's significant operative mortality and morbidity associated with this. If you look at outcomes of endovascular intervention in aortoiliac cases, in TAS D cases, TAS C and D cases, I draw your attention to this meta-analysis in which 4 and 5-year outcomes had extremely good secondary patency rates and even primary patency rates. With stenting bilateral common iliac arteries with balloon expandable stents, balloon expandable covered stents, and stenting the external iliac artery with self-expanding stents all the way to the proximal common femoral, we were able to get an extremely good outcome in this case. We were able to close both groins with closure devices, a TR band on the radial side. We were able to finish this case in about 2.5 hours, and the patient went home the same day. So in short, when you're talking about crossing complex aortoiliac interventions, anticipate complications. Anticipate complications like perforations. If you've already crossed the occlusion, be prepared to use covered stents. Sometimes, however, you may have to use coils as well, especially if you haven't been able to cross and stent this, but still have significant perforations that require coiling. Recognize thrombotic occlusions like what I showed you. If you do not, you can have significant distal embolization and make the procedure even worse and have significant complications from it. Use embolic protection like I showed you if you think you need it. In summary, study the angiograms, study your CT scans, have a plan. If that doesn't work, have a plan B or a plan C. Know what equipment you have on your shelf. And more importantly, it's important that we all know what limitations we have. Thank you.